So, welcome to all of you again. This is a presentation that is the fourth of our Olmstead training series for our CFILC's project called Californians for Olmstead. We're delighted to present on the topic of follow the money, using cost effectiveness in advocacy for long-term services and supports. Next slide. As I said, the series is brought to you by CFILC. Next slide. And this just records for posterity the date and time. As I said, this will be posted on our website in about 2 days. And so anybody that missed this webinar that wants to see it will be able to see it exactly like it plays today just by going to the Californians for Olmstead website and going to training materials. So we're really delighted to have with us today Dr. Stephen Kaye. He's very informal with us, and we all call him Steve. But he's with the University of California, San Francisco Institute for Health and Aging. Next slide. I've introduced Alan Friedman, the Technologies Manager for CFILC, Rhett Simmons from West Coast Captioning, and I'm Laurel Mildred, the Olmstead Advocacy Director here at CFILC. Next slide. So I wanted to just begin today's training by framing a discussion about cost effectiveness, because we've actually covered some of these ideas in previous trainings, and I just wanted to step back and revisit the idea that cost effectiveness is one tool in the toolkit of advocating for Olmstead implementation. And so we have this very nice quote from Paul Longmore, sort of reminding us of the big context of Olmstead advocacy. And you can see there Paul said, advocates have sometimes argued that funding community-based living and in-home support services is less expensive than institutionalization or nursing home placement. But more important than that pragmatic argument, they have asserted not only the right of people with disabilities to live in the world, but also their right to the means to make that right effective. Next slide. So cost effectiveness, Joanne, if you want to use the headset, you can hear. Cost effectiveness is not the only argument for implementing Olmstead. The primary legal rationale for the decision is that segregation is fundamentally illegal. However, if understood correctly and used with care, cost effectiveness can be a powerful argument for advocates. So today's training is going to focus on that pragmatic argument, the research that demonstrates cost effectiveness of home and community-based services. Next slide. So it's my pleasure today to introduce our guest presenter, Dr. Kaye. He's with us remotely from Washington, D.C. today. And he's a professor at the Institute for Healthy Aging in the Department of Social and Behavioral Sciences with the University of California, San Francisco. He's the co-principal investigator of the Center for Personal Assistance. He received his Ph.D. from Stanford in 1983. I'm going to give you just a little bit of his professional focus and accomplishments here. If you're looking for Steve's published work, his full name is H. Stephen Kaye. As I mentioned, he serves as the co-principal investigator for the Center for Personal Assistance Services, a rehabilitation research and training center funded by the National Institute on Disability and Rehabilitation Research. As co-director of the UCSF Disability Statistics Center, and as co-principal investigator of the Pacific ADA Center. And he's going to take us to their website and give us a little bit more information about them a little later in the presentation. As I mentioned, he graduated with a Ph.D. from Stanford University in 1983. His research includes a groundbreaking 2000 study on the effect of the digital divide on the disability population. the Disability Watch series of reports on the status of Americans with disabilities, and recent journal articles on the relative expenditures on institutional and non-institutional long-term care, disparities in usage of assistive technology, and the impact of the Great Recession on workers with disabilities. And if you didn't know, he's also a board member of Community Resources for Independent Living in Hayward. And Sherry Burns, the Executive Director of CRIL, is here with us today. So with that, I want to welcome Steve, and I'm going to turn the presentation over to him at this point.
Well, thank you very much, Laurel. Now, do you want me to advance the slides, or do you want to advance the slides?
You can do it however you want to, if you can remember to say next slide so that the screen readers can follow you.
Okay, I'll do it myself, and I'll try to remember, and you can remind me if I forget.
Perfect.
Well, good afternoon, everybody. It's very hot here in Washington, D.C. I wish I were back in California. There are 4 parts to the presentation. Brief introduction, which is basically why do we care about cost effectiveness, or do we even care at all? The second part is a fair amount of detail about some research that I published a couple of years ago on the cost effectiveness, or the so-called cost effectiveness, of home and community-based services. The third part is some new research that is not yet published. I think this is the second or third time I'll be presenting it, on how does rebalancing of long-term care expenditures affect the overall long-term care spending, and then some concluding remarks about how I think we should try to reframe the discussion about home and community-based services. So on the next slide, I'm just starting the first part, cost effectiveness. Do we care? Well, not really. There are, from my perspective, there are sort of 4 different constituencies involved in this discussion about home and community-based services. There are the advocates who basically are of the position that we should fund home and community-based services because it's the right thing to do, because, as Laurel said, it's the legal thing to do. Advocates will go on the streets and yell, "Free our people." That's not about cost effectiveness. It's about doing the right thing. As I mentioned, there are the lawyers who say we should be obeying the law. That's not about cost effectiveness. There's the researchers who worry about whether people's needs for services are being met. And I mean, that's really what we're concerned about. People's needs for services need to be met, and cost is a secondary consideration. Politicians, for their part, want to reduce waste, they want to get rid of fraud, they want whatever axe they have to grind, and it's not really about cost effectiveness. It might be about cutting the budget. That's a different question. So in essence, as a fundamental kind of principle, cost effectiveness is kind of, not at the top of anybody's list. Next slide. However, policymakers often blame home and community-based services programs for the fact that Medicaid budgets are always increasing. Long-term care expenditures become, over time, a higher and higher percentage of state Medicaid budgets. Home and community-based services become a higher and higher percentage of long-term care spending. And so, the obvious thing to blame is home and community-based services. They're not effective, and therefore home and community-based services are not, quote, cost-effective. That's what they say. And people who believe that argue that the lack of cost-effectiveness is a reason to cut home and community-based services. It's a powerful argument. It's not a correct argument, but it's a powerful one. And we see this right today with these constant cuts or constant threats, and then eventual cuts to IHSS, to adult day health care. MSRP has been eliminated or cut. And that's because legislators think, well, there are two reasons. One is that legislators think that it's not cost effective, and the other reason is that it's something they can cut because it's not mandated by the federal government. So I think it's critical for advocates and for researchers like me to be able to counter the message that home and community-based services are not cost effective. So if we do care about cost effectiveness, that's why. Well, to discuss what we mean by cost effectiveness, people use the term loosely. I thought I'd start with the question of what is effectiveness and what is cost effectiveness. So there's terminology that gets thrown around. Effectiveness is obviously, do home and community-based services, do non-institutional services actually work? There's comparative effectiveness, which is a tremendous buzzword here in Washington these days. And comparative effectiveness means, do non-institutional services work better than institutional services, for example? I would say yes, they do, but that's not the discussion we're here to have today. We want to talk about cost effectiveness. Okay, well, what does cost effectiveness actually mean? Well, wait a minute. On the next slide, I'm getting ahead of myself. When we talk about effectiveness, it's actually important to talk about, to think about what we mean by effectiveness. And this is a point I want to make because it gets away from us often. We're sometimes trapped because people talk about effectiveness in ways that are not very relevant to an independent living perspective. People talk about effectiveness in terms of medical model measures such as reducing hospitalization, reducing return to hospitalization, reducing injury, secondary conditions, reducing mortality. Fine, those are good, but they're not enough. We have independent living measures. We want to talk about, an obvious one is avoiding institutionalization, being able to remain living in the community. We want to talk about enhancing a person's independence, their ability to participate in the community, their self-determination, and so on. So getting back to what I started to talk about before on the next slide, cost effectiveness is, the question about cost effectiveness is, does it cost less to meet a given person's needs in the community than it does to meet those needs in an institution? Okay? I mean, that's the basic question of cost effectiveness, and there really isn't much of a debate about that. On the next slide, what we see is the lines in blue show the typical monthly expenditures for people getting home and community-based services. 87% of those were less than $3,500 a month. Most of them were much, much less than $3,500 a month. The majority were less than $1,500 a month. So home and community-based services are, for most people who are getting them, relatively inexpensive. Compared to nursing home services, which are shown in red in this graph, 92% of those were more than $3,500 a month. This is the monthly cost in $2,009. And so it's really not, it's still somewhat controversial, but most people who see this kind of data say, okay, you know, on an individual basis, it really is less expensive to provide services to people in the community, to most people in the community, than it is in nursing homes. You might stop me and say, well, isn't there a big difference in the level of disability between people who are living in nursing homes and people living in the community who are getting home and community-based services? Yes, there is, but it's much less than people think it is. So on the next slide, so cost effectiveness is not really, the argument about cost effectiveness is not really how much does it cost to provide services to one person. What people really mean by cost effectiveness in the policy context is program cost effectiveness. In other words, if you offer or expand your home and community-based services programs, does the whole cost of long-term care services go up or down? In other words, are home and community-based services responsible for long-term care expenditures that have been, basically going through the roof, or at least that's the perception? And on the next slide, this is often phrased in terms of the Woodwork effect. And what that means is people come out of the woodwork, in quotes, to get home and community-based services. In other words, people who would not have previously applied for services if only nursing home services were offered suddenly, quote, come out of the woodwork and apply for home and community-based services. I mean, is this offensive terminology or what? Are people with disabilities cockroaches who come out of the woodwork? No. But that's the term that people use in Washington. And they say, why should government pay for services that families are already providing? Well, but do they know that? Are the families really providing services? Are people's needs really being met? And at what cost to the family? So people who talk about the Woodwork effect are sort of assuming that rather than filling a need that really exists, that people are coming and applying for services who could otherwise be served perfectly well in their own families. I don't think that's true. So on the next slide, here are numbers of people, well, the proportion of the population in California that was receiving home and community-based services through the IHSS program, home and community-based services through waiver programs, and nursing home services between 2002 and 2008. In blue is the line for IHSS, and it's gone up quite a bit from 0.8% of the population in 2002 to 1.1% of the population in 2008. So there was a big increase in the number of people receiving services. There was a decline, you can't see it so well on this graph, but there was a fairly substantial decline in the proportion of the population in nursing homes over the period, and waivers remained pretty much flat. So if you're one of these Woodwork effect people, you'll say, aha, look, there are lots more people getting long-term care in California because IHSS is serving so many more people than have actually left nursing homes. The people at Freed are asking, is there duplication in the numbers receiving IHSS and waiver services? Yes, there are. There is duplication. On the next slide. So back to the Woodwork effect, the so-called Woodwork effect, which is basically offering home and community-based services increases participation in the program. I mean, we saw this just now with California, and it's true in general. But so what? By favoring nursing homes, by only offering long-term care services in nursing homes, what you're effectively doing is rationing services by offering services that nobody wants. But on the other hand, you're serving a whole lot more people for what I'll show you is the same money. And isn't that what's supposed to happen? Isn't a government program supposed to serve everybody who's eligible for services and needs them? So an alternative definition of the so-called Woodwork effect is not that there are more people who are getting services, but that the program costs go up because more people enroll. So on an individual basis, it's cheaper, but when you add all the large numbers of people who are now getting services that weren't before, then the programs cost more. At least that's what people think. So on the next slide, here are California long-term care expenditures between 2001 and 2008, separately for IHSS in blue, nursing homes in red, waivers in green. Waivers are very low. These are expenditures as a percent of the gross domestic product of California, which is just a way I like to show them. It kind of adjusts for inflation and the size of the population. IHSS expenditures really did go up quite a bit. So there were more people getting services, and the cost of services certainly didn't go down. So their total expenditures went up by quite a bit. Now nursing home expenditures in red they started going down between 2002 and 2005. After all, there was a decline in the number of people in nursing homes over that period. So adjusting for inflation, they really should have gone down. But something happened in 2006, and they went up again, and maybe they're starting to go down again. They're starting to go back down. I'm going to talk about that later if I have time, about what happened there. But so in effect, in California, there was actually an increase in total program costs as participation in IHSS increased. So home and community-based services budgets increased, but of course it's not just about home and community-based services. The real question is the entire long-term services and supports budget, what happened with that? If we can show that not in California necessarily, but in the nation as a whole, long-term services and support budgets decreased when HCBS was expanded, if we can show that, in other words, that if you offer home and community-based services, you don't see a huge increase in long-term care spending, then that helps our argument that home and community-based services are, quote, cost-effective. In other words, does rebalancing, so-called rebalancing, save money? Does it cost more, or is it cost neutral? And another question to ask is what happens when home and community-based services are cut, as is happening in California and unfortunately many other states too. So in the next slide we start part 2, and we're about to launch into some technical details. Are state home and community-based services programs cost effective? Okay, on the next slide, just to define some terms, what are home and community-based services? When I use the phrase home and community-based services, or HCBS, I'm talking about Medicaid home and community-based services. In other words, waiver programs and personal care programs, home health programs provided under Medicaid, which in California would be Medi-Cal. When I use the phrase per capita expenditure, I mean the total budgeted amount spent, or the total amount spent divided by the population of the state. This is not divided by the number of participants in the program. So it's not a per person expenditure, it's an expenditure divided by the population. When I say inflation adjusted, I'm adjusting for the increase in the cost of health care, not just the costs of consumer prices in general. So this is a pretty big adjustment I'm making, but it makes the argument cleaner if we adjust for.
So Steve, I think you kind of moved your mic away from your microphone a little bit, and Alan, can you take away the conference line phones, please?
Okay,
sorry, Steve.
How's my sound now?
It's okay.
Okay. All right, I'm going to divide the disability population into 2 groups. The group I'm calling the IDD population, which is people with intellectual or developmental disabilities, and I'm going to refer to the non-IDD population because I don't have a better term for it, which is any other type of disability but intellectual and developmental disabilities. Finally, a definition, what an ICFMR is an institution for people with intellectual or developmental disabilities. All right, on the next slide, for the nation as a whole, I'm showing the per capita Medicaid expenditure on home and community-based services by the type of service offered, adjusted for inflation. Okay, so I've already taken out the fact that that healthcare costs have gone up tremendously, and even after having done that, it's clear that IDD waivers, expenditures on IDD waivers, have gone up threefold between 1995 and 2009. So a huge increase in IDD waivers, that's shown in light blue on this graph. Now, if you can turn your attention to the red line, which is non-IDD waivers, they've also gone up by threefold, but their expenditures are much lower. The orange line is for personal care services, which was flat during the beginning of the period and then started to increase rather rapidly in around 2000. The green line is for home health services, which are flat and are basically not very interesting to this analysis. Now, the next slide shows per capita Medicaid long-term care expenditures by type, and in this case I mean whether they are institutional services, non-institutional services, in other words, home and community-based services, and we also have the total services. Institutional services are shown in red, that's nursing homes and ICFMRs, and after adjusting for inflation, they increased between about 1988 and 1991 or 2. Then they were flat for more than a decade, and then they started to drop rather precipitously beginning about 2001. In contrast to that, expenditures on home and community-based services have been going up pretty steadily and very dramatically overall between over the period shown. And adding these two together, we get the blue line on top, which shows that total home and community-based, total long-term care expenditures increased quite a bit after adjusting for inflation between 1988, and about 2002, and then went flat. So if you look at this graph, your temptation might be to say that because the green line for HCBS is going up, and so is the blue line, that home and community-based services are responsible for the increase in long-term care costs, but that, of course, is not necessarily the case. On the next slide is the title and abstract of a journal article that my colleagues Mitch LaPlante and Charlene Harrington and I published in the journal Health Affairs in early 2009. Do non-institutional long-term care services reduce Medicaid spending was the title of that article, and I'm going to present you the analysis and the findings from that. The methods we used were to examine annual state Medicaid expenditures for nursing homes, for ICFMRs, home health, personal care plans, and HCBS waivers, so basically all of the services that fall into the long-term care category. And examine those expenditures and combine states with similar spending patterns, and then examine trends in those combined states between 1995 and 2005. So this is a rather simple and straightforward analysis. Look at the states, combine the ones that are similar, and just present the results. And then what I did was to do separate analyses of the IDD population and the non-IDD population. In other words, programs for people with intellectual and developmental disabilities, which is versus all other programs. And the reason that I did that is shown on the next slide. Basically, this is a slide showing the proportion of long-term care expenditures that went to home and community-based services over the period 1995 to 2009. And IDD expenditures are shown in green, and they started going up quite fast early in the period, between about 1996 and, say, 2000. And then they kind of started to level off a little bit. But they've been going up all along, even way at the beginning of this program, of this period that I'm showing on this graph. In contrast, expenditures on non-IDD programs were pretty much flat until about 2000 or 2001, and then they started going up. So the reason I'm showing you this is to distinguish between the IDD spending, which went up early, the non-IDD spending, which went up later, and that's why I'm dividing these two population groups before I do the analysis. Okay, so on the non-IDD side, what I'm doing is to compare institutional expenditures, which is basically nursing homes, with non-institutional expenditures, which is waiver programs, except waivers explicitly for people with intellectual and developmental disabilities, personal care plans, and home health. I forgot to say next slide, and now I'm going to say next slide again. This is a map showing the percent of non-IDD long-term care expenditures that were devoted to HCBS. And in 2005, Tennessee spent only 1% of all its long-term care expenditures on HCBS, which is pretty appalling. They're a little. This is 2005. They're just a little bit better now. They're still the worst in the country, I think. In contrast to that, California was at 49%. The highest were Oregon at 54%. Alaska 53%. So several Western states are doing pretty well, spending half or more than half of their long-term care dollars on home and community-based services. Some states, mostly in the South, are doing pretty badly. On the next slide, I'm showing you how I divided the states into three groups. At the bottom, in blue, is the low HCBS states, which are states that spent, it's the half of all the states that spent the least on, spent less than the typical amount on home and community-based services. And it's rather low, and it stays pretty low throughout the period. There is an increase, but it's hardly very dramatic. At the top here in brown is one of two types of high HCBS states. I'm calling these established HCBS states because they started out high. They started out at about $40 per capita adjusted for inflation, and ended up a little bit higher, not very much, just under $50 per capita. So these are states that in 1995 already had well-established home and community-based services programs, and they went up a little, but they didn't really expand much. Okay, the third category is shown in green here, and that's the expanding HCBS states. They start out as low as the low HCBS states at around $13 per capita, but they increased very dramatically over the program, over the time period, more than 3 times as much to about $53 per capita. So there are 3 different groups: low HCBS states, established HCBS states, which are high throughout the period, and expanding HCBS states, which grew their HCBS programs during the period. On the next slide, I'm showing you the three different types of states, but instead of their HCBS expenditures, this is the nursing home expenditures, so we're now on the institutional side of things. The low HCBS states, again, are shown in blue, in light blue here. Their expenditures increased up until 2002, and then they went down somewhat. But at the end of the period, their nursing home expenditures, after adjusting for inflation, are a little bit above what they started out as. Okay? In contrast to that, and actually rather sharp contrast to that, is the brown line, which shows established HCBS states. Their nursing home expenditures started going down very early in the program. They flattened out, and they started going down again. So their 2005 expenditures are actually quite a bit less than their 1995 expenditures. Similarly, for expanding HCBS states, their expenditures started dropping fairly early on, went up a little bit, and then dropped again. So again, as with the established HCBS states, they're lower. Their nursing home expenditures are lower than they were lower in 2005 than they were in 1995. Now this is actually important because when we published this, it wasn't even established that if you increase home and community-based services, or if you have community-based services, you actually reduce nursing home expenditures. Yeah, you do. It makes a difference to your nursing home expenditures. So that's good. And on the next slide, we add together those two types of expenditures, and what we see is that for low HCBS states, there was an increase, something of a decrease, but their final total expenditure is a fair amount higher than it was to begin with. Okay? Now in contrast to that, the established HCBS states, their expenditures actually dropped quite a bit. From just under 180, say it's about $179 in 1995, to about $162 per capita in 2005 after adjusting for inflation. So the established HCBS states did much better than the low HCBS states in controlling their long-term care costs. However, unfortunately, the expanding HCBS states, I think because they were expanding during the period, they were rapidly increasing their home and community-based services expenditures. Their final expenditures are actually much more, so they did not do a good job at controlling their expenditures. So on the next slide, just to clarify that we're switching from the non-IDD population to the IDD population. And when I talk about institutional expenditures here, I'm talking about ICFMR. When I'm talking about non-institutional, all I'm talking about is waivers specifically designated for people with intellectual or developmental disabilities. They're called MRDD waivers. Okay, the next slide is the same kind of map as I showed you before, only this time it's the proportion of IDD expenditures that are spent on home and community-based services. This time it's Mississippi that's the lowest at 14%, but Oregon and Alaska, 100% of their IDD expenditures go to home and community-based services. In other words, they have no institutions. They have closed all their institutions for people with intellectual and developmental disabilities. I don't know that Alaska actually ever had any. I think they did. California's pretty good, 62%. Again, but not as good as Vermont, New Hampshire. There are several states that are actually better than California. But it's somewhat different. It's somewhat different from the non-IDD side, mostly because the percent going to home and community-based services is so much higher. Okay, so here are the waiver expenditures. This is HCBS expenditures for 3 different types of states. This time this is a different grouping of states because this time I looked at their IDD expenditures. But once again, I've divided between low HCBS states, which are in blue again, expanding HCBS states in green, and established HCBS states in brown. And the difference here is that for all 3 types of states, there's a substantial increase in expenditures for home and community-based services, even the states that didn't do any kind of rapid expansion. In other words, basically all the states were doing something. On the next slide, now I'm looking at the institutional side, and once again, this time there is a decline in institutional expenditures for the low HCBS states, but it's rather modest compared to a huge decline in the established HCBS states, which started almost immediately. So expanding HCBS on the IDD side seems to have a really dramatic effect on institutional expenditures. In other words, what they're doing is they're transferring people out of institutions and then presumably shutting down those institutions, so they actually reap a savings. In expanding HCBS states, there was also a dramatic decline in institutional expenditures, but it started later and isn't quite as dramatic. Okay, on the next slide, I'm adding together the 2 expenditures, ICFMR and IDD waivers. And again, the blue line is low HCBS states. Their expenditures went up steadily over the period. The brown line is the established HCBS states. They went up at first, but then they settled down. They're the only group to kind of settle down and be flat through much of this period. And again, once again, both of those types of states did better than the states that were rapidly expanding their home and community-based services over the period. So in both cases, what you see is if you have a well-established home and community-based services program, you do better at controlling your long-term care spending. The second part of this analysis here is what happens when states rapidly expand their home and community-based services. What I'm going to do is examine states that introduced new or greatly expanded home and community-based services in the late 1990s. And the reason for picking those years is we can follow their expenditures over the next several years. On the non-IDD side, there were 9 such states, and I'm going to compare those with 15 states that basically didn't do anything to home and community-based services on the non-IDD side. And on the IDD side, I'm going to look at 11 states that rapidly expanded their expenditures, and there really aren't any comparison states because all the states were expanding their programs over the time period. So on the next slide, here's what it looks like. Here's what home and community-based services look like on the non-IDD side for states that rapidly expanded their programs. And what happens is over a 2-year period, there is a very rapid increase in expenditures, almost a doubling of expenditures, and then things level off. That's actually a fairly common pattern. It takes a couple of years for the program to really get into full swing, and then it flattens out. So on the next slide, we're adding in nursing home expenditures, and what happened as the HCBS programs were expanding, nursing home expenditures remained flat for several years, and then they went down rather extensively. So now when we add those two together, we get the black line, which shows an increase in total long-term care expenditures for about 5 years, followed by a decline. So it looks like, anyway, I mean, the impression you get is that if you increase your home and community-based services expenditures, you do see a savings over this dashed line, which is what the comparison states that did nothing did. But the cost savings takes a while to show up. So in other words, you're operating 2 different systems at one time, and it takes you a while to actually reap any benefit from that. Here is the same kind of analysis on the IDD side. Again, over a 2-year period, rapid increase in expenditures, almost a doubling of home and community-based services, and then it went flat. In this case, the ICFMR expenditures dropped exactly as the home and community-based service expenditures were increasing. Add those two together, and you get a couple of years of increase, followed by flat. And as I said, we don't have comparison data to see what would have happened had the states done nothing. I forgot to say next slide, and here's my conclusion slide for this section of the talk. Have states found home and community-based services programs to be cost-effective, quote, cost-effective? Well, it's clear that home and community-based services do not break the budget. There is actually surprisingly little difference between total expenditures in high and low HCBS states. I didn't show you what happens if you just look at all the high HCBS states together. You don't really see any difference at all compared to the low HCBS states. And it's also pretty clear that states with well-established home and community-based services programs contain costs better than states with low HCBS. I have to make the caveat that it's probably not automatic that you get institutional savings when you increase your home and community-based services. Probably you need to do something to make that happen. You need to institute policies that cause nursing home expenditures to go down. So my conclusion from this part of the talk was that HCBS expansion seems to increase short-term spending, but may actually cut long-term spending. And what you're doing is serving more people at equal or presumably lower cost, which I think is a big victory. Okay, the next slide introduces part 3 of the presentation. In this case, I'm going to show you some brand new analysis. How does long-term care rebalancing, how does rebalancing affect long-term care spending? And on the next slide, I'm describing my new approach to this analysis. And let me remind you what rebalancing is. It's jargon for shifting funds from institutional to home and community-based services. In other words, increasing the percentage of long-term care spending, long-term care dollars going to home and community-based services. So this time, rather than just doing the simple analysis where I add together states that have similar patterns, I'm going to use statistical techniques. I'm going to make a statistical model to explore the effect of rebalancing on long-term care expenditures. And what I'm testing is whether the change in the percentage spent on HCBS affects overall long-term care spending. In other words, I'm testing whether when you actually rebalance your expenditures, how does that affect long-term care spending? And this time, rather than lumping together waivers, personal care services, and home health services, I'm going to divide those and analyze that separately. And I'm going to expand the time period. This time I'm analyzing data between 1995 and 2009. So on the next slide, data sources and adjustments to the data. I'm using the same type of data, the same state expenditures data that I get from basically from Center for Medicare and Medicaid Services, and I'm separating IDD again, spending from non-IDD, and this analysis that I'm showing you is focusing on only non-IDD expenditures, and once again I'm going to calculate per capita inflation-adjusted expenditures, and I just do some correction for things that are obviously wrong, including something that I discovered recently, which is that states were actually getting away with murder in billing the federal government for their nursing home expenditures, and it sort of artificially increases nursing home costs for certain years. Okay, on the next slide, the first thing I did was to take a look at state expenditures over the period and see what rebalancing actually looks like in the states. So I'm going to show you a slide with a whole bunch of states, and this is a kind of baseline thing, what happens if you don't do any rebalancing. And then I'm going to show you gradual, steady rebalancing, and then I'll show you a rapid shift in HCBS spending pattern and see if we can detect, see if we can figure out what's going on. It's not so easy. And each graph for the state has a blue line, which is the total long-term care expenditure per capita, same as I was showing you before. And the scale is on the left side. So there's the blue line and the scale is on the left side, in this case $0 to $400 per capita total long-term care expenditure, okay? The red line, the scale is on the right side, and it's the percent of long-term care spending that went to home and community-based services. So in other words, Wisconsin over this period increased they rebalanced over this period. They shifted funds from institutional to non-institutional spending, and the effect of that was to reduce their long-term care expenditures. I mean, that's good, right? That's Wisconsin anyway. So on the next slide, there are a bunch of states. These are pretty much all the states that didn't do anything, basically did nothing to rebalance their long-term care spending, as you can see from the pretty flat red lines for each of the states. And the blue lines are pretty flat too. I mean, so the inflation-adjusted long-term care expenditures really don't change much. There's this thing going on in Delaware that I can't explain. I don't know what happened there. But for most of the other states, there wasn't a whole lot of movement in their long-term care expenditures. So it looks like not doing anything has no effect. Good. Okay, on the next slide, here are a bunch of states that gradually rebalanced over the period. So in each state, the percentage of long-term care expenditures that went to home and community-based services went up. That's true in all these states here. And what happened? Well, it depends on the state. Connecticut is pretty flat. Iowa went up and then got flat. Massachusetts was flat and then went down. Ohio went up and then went down. Rhode Island went down. South Dakota went down. Wisconsin was flat and went down. Wyoming was flat. So it's not consistent, but there's more going down than there is going up, right? So you rebalance, it looks like you rebalance gradually. It looks like you're more likely to save money than not, I would say. Okay, on the next slide, finally, is states that rapidly increased their home and community-based services expenditure over the period. And so Alaska went gangbusters. They did a huge amount of rebalancing. They start from very low percentage devoted to home and community-based services at the beginning of the period to one of the highest, I think actually the highest in the nation, at the end of the period. And unfortunately, their long-term care expenditures kind of went crazy. First of all, they stayed flat for a while as they were increasing. Then they went up like crazy, and then they went flat again. Who knows what's going on there? And in these other states, well, here's Idaho. They rebalanced and their expenditures went up. Here's Illinois. They rebalanced and their expenditures went down. Louisiana did a little rebalancing and theirs went up. So, you know, there's not much consistent here. New Mexico went gangbusters in rebalancing starting in 2001, and their expenditures went up. It's not consistent. And I looked at that and I said, well, I wonder if it depends on what kind of program they shifted their money into. And so this slide, the next slide, well, here's something interesting. Now the red is waiver expenditures, and the green is the percent on personal care plans. And what Alaska did was they started at the beginning of the period rapidly increasing their waiver expenditures, and that didn't have much of an effect on their spending. But when they started increasing their, I think they actually initiated a personal care plan, that had a huge impact on their expenditures. So maybe there's something going on here, that there's a difference between a waiver and a personal care plan. Here's Illinois, in which waivers increased while overall spending went down. Here's Nevada, where waivers increased and expenditures increased, right? So it's still not completely consistent, but there does seem to be something going on here. Look at New Mexico. That was a new personal care plan, and their long-term care spending increased rapidly. You know, there's a big difference between personal care plans and waivers. Waiver programs are targeted toward people with a so-called institutional level of need. You need to have a fairly substantial disability. You need to have quite a bit of need for assistance in daily activities in order to get on a waiver. That's not true of personal care services plans like IHSS. So you might say that there's a difference going on here between waivers, which are very targeted towards people who might be going into an institution, and personal care plans, which are not. So what happens when I actually run the statistical model? I think I was not intending to show this slide. It was meant to be hidden. I wasn't going to give you the details of the model. So here are the predicted expenditures, predicted long-term care expenditures. So this is the result of my modeling. And what I'm showing you is an example of what would happen if a state gradually increased, Now what would happen if a state did not do anything to rebalance their expenditures? So this, what color is that? Orangey color here for home health is flat, so is the purple for personal care, so is the green for waiver programs. Nursing home expenditures in red here went up a little bit, and as a result of that, the total expenditures went up by 6% over a 10-year period. So remember this increase of 6% over a 10-year period if you do nothing. That's what my statistical model tells me. Okay, on the next slide, here's what happens if you rebalance using waivers. In other words, you shift your money from nursing homes into HCBS waiver programs. And now you can see that the green line here goes up gradually over the 10-year period, and the red line representing nursing homes goes down rather substantially. And instead of getting an increase of 6% over a 10-year period, you get a decrease of 10% in your total expenditures. So we increased our waivers gradually. We shifted money from nursing homes to waiver programs, and we saw a substantial decline in nursing home expenditures that was more than the increase in waiver expenditures, and in total we got a fairly nice decline in total long-term care expenditures. Now, the second graph here, the waiver expenditures are increasing more rapidly. The rebalancing in favor of waivers is happening faster, and there's a little bit less of a saving. So it seems to matter a little bit whether you do it kind of gradually or whether you do it quickly. On the next slide, I'm showing you the effects of rebalancing by, instead of shifting spending to waivers, shifting it to personal care plans. On the left is a gradual increase in personal care plan spending. Again, there's a decrease in nursing home expenditures and a 6% decline this time. Still a fairly substantial decline in total long-term care expenditures. So we would have, if we'd done nothing, we would have been up by 6% in 10 years. If we shift to personal care plan, we're down by 6%. So we're doing pretty well, not quite as well as waivers, but still pretty well. However, if we rapidly shift to a personal care plan, we go gangbusters like they did in Alaska and in New Mexico, we actually are going to see an increase in expenditures of 4%, almost as much as we would have had if we did nothing. So my model is basically confirming what I was suspecting from looking at the states, that it matters whether you shift to waivers or personal care plans. If you want to save money, your better bet is a waiver. However, if you do what is happening in California and in lots of other states now, if you reduce the amount of expenditures, the amount of spending in waiver programs, in other words, if you unrebalance your expenditures, then you see a large increase in nursing home expenditures according to the model, and a very large increase in total expenditures for home and community-based services. So don't cut waivers, in other words. Well, don't cut personal care plans either, because although you don't see quite as dramatic an increase, there's still an increase in expenditures when you cut home and community-based services of either type. So this is what the model predicts. The model predicts that California will be spending more money because it's cutting its home and community-based services programs. Okay, so on the next slide, in conclusion, Medicaid long-term care expenditures vary due to changes in home and community-based services spending and other factors that I haven't measured. So changes in home and community-based services spending is only one contribution. It's the one that I can measure here, and it does seem fairly convincing to me anyway that we're getting that the model actually significantly predicts that changes in that rebalancing has an effect on spending, and rebalancing has a good effect on spending. So then the effect of rebalancing on the non-IDD expenditures is that if you increase HCBS spending that is well targeted to high needs population, in other words through waivers, you're pretty likely to reduce overall long-term care spending. That's good. Increasing toward more broadly targeted home and community-based services either saves money if you do it gradually, or it's cost neutral. So personal care plans are also good. They're good for a lot of reasons, and they can also be good for saving money. And cutting home and community-based services, reducing the amount of long-term care budget that's going to home and community-based services is pretty sure, according to the model, to increase long-term care spending. It's a bad idea. All right, let me wrap up by talking about reframing the discussion about home and community-based services spending. That's the next slide. And the slide after that. So I want to reframe the discussion from how do we cut IHSS, which is what politicians in California want to talk about, what the legislators in California want to talk about. How do we cut IHSS, they're always saying. Instead of talking about how do we cut IHSS, I want to talk about how do we contain overall spending on long-term supports and services. So, don't talk about just one budget. Lump everything together, nursing homes, ICFMR, etc., and talk about how do we cut the entire budget. Why do we have to cut IHSS? Why don't we cut nursing home spending? And the evidence, in fact, suggests that maintaining or even increasing home and community-based services helps contain costs. It also suggests that cutting IHSS is a bad idea. The next slide, I want to reframe the discussion from talking about the, quote, Woodwork effect to talking about the cost-effectiveness of home and community-based services and their cost-effective way of serving more people for less money. I want to talk about the fact that home and community-based services are meeting needs that were previously unmet for services, including for people who didn't have family support or their family support was not adequate. I want to reframe the discussion from talking about just reducing healthcare expenditures or reducing long-term care expenditures, which is what I've been talking about. I want to expand that thinking to include non-medical outcomes. I haven't really talked about this, but what about the values to society of keeping people independent, participating, thriving? And there are economic costs unrelated to healthcare, and there are social costs unrelated to healthcare from having people who are living in nursing homes who could otherwise be living in the community. And on the next slide, I want to reframe the discussion from the current situation in which Medicaid programs are required to provide nursing home benefits, their mandatory benefit under Medicaid, and home and community-based services are expendable. I mean, as I said, people want to cut HCBS partly because it's something that they can cut. And I want to shift the discussion from that state of affairs to one in which flexibility is actually possible. And it can be done. Vermont did it. They tried something different. It was an experiment that may not have worked out so well, but that doesn't mean the principle is bad. What they did was they eliminated the entitlement to nursing home placement. And instead, they created a system in which people who had the highest level of need for services were basically pretty much guaranteed, not quite guaranteed, to get whatever kinds of services they want. So they could, on an equal footing, get either home and community-based services or nursing home services. People with less need got either got the services that they wanted, or they were put on a waiting list for services. This seemed like a much fairer way of allocating resources to me. And I want to reframe the discussion on the next slide from people who talk about fraud and abuse and whatever they talk about, to shift the discussion to talking about the good things about IHSS, waiver programs, other home and community-based services. Thanks to those services, for example, California is among the top states in balancing long-term care spending. That's great. And I did a little analysis that I haven't shown you, but without IHSS, California would drop to the second worst state in the United States, just above Tennessee. So remember, when IHSS was threatened with elimination, that's what would have happened. California would have become another Tennessee. Okay, Laurel asked me to give you a quick tour of the website of our Center for Personal Assistance Services. Laurel, do we have enough time for that?
Absolutely. Go ahead.
Okay. One moment. Okay, are you seeing the, Laurel, tell me whether you're seeing the
we were.
You were. Okay, you're not now. All right. So www.pascenter.org, PAS Center, no punctuation, .org is the website of the UCSF Center for Personal Assistance Services. Let me just, there's a lot of stuff here, a lot of stuff here. Let me show you some of the things that I think are fairly cool. Let me show you, if you click, as I just did, on the left side where it says state information, there are quite a few options for what you can get on a state-by-state basis. Let me start by showing you disability statistics, since that's stuff that I did. So I clicked on disability statistics. Now I'm going to click on disability data from the American Community Survey from 2009. That's the first link. And now I get a map of the states, or I can click on entire U.S. if I wanted to. And click on California. Okay, so the first, there are, I think, 7 tables here, 8. There are 8 different tables that you can look at. Let me click on prevalence. And I'm going to scroll down. And so here is the total population of California, of people 5 and over. And here's the number of people with disabilities in California, 3.8 million,
so
according
Steve,
to American Community Survey. Yes?
Sorry, we're not getting the detail. We just went to the site with you, but we are seeing the left navigation bar. But it doesn't seem to be following you to the sublink. Just to let you know, people aren't seeing that.
Oh. Okay, Alan, you got any ideas?
Yeah, you would have to do it as an application share. It's a different way of taking the people to the website.
All right, let me try it, although I think it actually is using application share here. Let me try it, see if it'll do it.
That's working.
It's working now?
Yes.
Okay, great. Thank you, Alan.
And people can expand that
so
window for themselves by grabbing the edges.
Oh, okay, that's what's going on. All right, I get it now. I'm showing you the prevalence of disability in California. By type of disability, for example, it says there are 1.5 million Californians with a cognitive disability. There are just under 1 million Californians who have difficulty in self-care activities. And here is a graph of the types of disability, of 2 different disability groupings for California. 5.1% have daily activity limitations, 6.1% have some other kind of disability, 88.8% have no disability. Let's see, what else should I show you? Employment status. Click on that, and you get, let's see, I will show you the graph. The employment rates for different types, for different disability populations for California. You'll have to explore this on your own. I'm going to go back to the state pages. I'm clicking in the left on Medicaid waiver data by state. California again, and there are data about the number of participants in the various programs. For example, IHSS, no, this is waiver data. For example, in the DD waiver, there were 66,000 participants in 2007. Here are expenditure data for California. Going back to the front page of the center, I want to click on the left side here, I'm going to click on PAS Center Publications. And oh look, here's one by me and my colleagues Lisa Jans and Erica Jones. And you can click here and it'll download an article for you, which you don't need to see. Why don't employers hire and retain workers with disabilities? So if you want to see our publications, that's a good way of doing that. I'm going to, along the top, there are various projects or audiences, and I'm going to click here on PAS users. Oops, PAS users, and I wanted to show you training resources. So we have an interesting module on training on how to be an employer of a personal assistant. Some people find this quite interesting, a training module. And another thing I wanted to show you was our Ask Mike section, which Mike Oxford, who's a prominent member of the National Council on Independent Living, he used to be the chair. He's the director of the Topeka Independent Living Center in Kansas, and he does an advice column, basically. So people write to him, and he answers their questions. And he does not make up the questions. He gets lots of questions. So Laurel, what else? There was something else that you wanted me to show, I think. Oh, the Olmstead Library, was that right?
Yeah, and just quickly, we're going to turn to questions for the last 10 minutes here, Steve, but if you have time to touch on the 2006 raise to nursing homes, I think you had a journal article or a piece about that, and maybe you just want to refer people to that.
Do I? I don't think I do.
you do on there somewhere, but it's okay. I think people have learned how to use your website and how to look for things. I just thought that was an interesting piece about, there was an analysis about the raise to nursing homes or nursing home expenses. But I think you've covered it extremely well, and I think there may be some questions that people have for you if we want to turn back to the chat room and take some questions now from people. There was one question while you were talking that was, in general,
all attendees have been unmuted.
Okay, so people on the phones now have the ability to speak up, and people on the computer can either use the chat or they can speak up. In general, has your analysis considered whether for-profit services cost less? Was the question from the chat box.
No, I don't have any way. In this way of doing the analysis, I can't do that. We do have, my colleague Charlene Harrington studies nursing homes. Well, she studies a lot of things, but one of the things she does is look at for-profit nursing homes, especially those taken over by large chains, to see what the effect of that is, and it's not good. She probably has some publications on our publication page.
Great. Well, I'll just make a couple of observations, Steve. You just gave us so much wonderful information, and I'm actually going to go back when I'm not trying to moderate it and watch the bells and whistles, and Red isn't reminding me to speak slowly, because there were a few things that I really wanted to understand the details. So do remember, if you wanted to catch something in this, you can always just rerun it and hear the explanation again. But a couple of the things that were really interesting to me, Steve, were your analysis that well-established programs are like the gold standard, that they are the way to do that gradual expansion, which is where the cost savings is going to come in. And that was really interesting in the context of, you know, if you were a state that was rapidly expanding, you might make a pragmatic decision to continue that or not to continue it. But if you are a state that has a well-established program, it would be just really destructive to your ability to save money over the long term to take apart that well-established program, because there's value in the ability to be cost-effective from that well-established program. And so it makes what happened last year doubly significant when it was proposed that IHSS would be eliminated, because it would be like, I don't know, like a really well-established business or something that's just got a lot of capital, and just taking it apart. You lose more than just what you provide this year. You lose all of that value of having the well-established program. Is that a fair observation from your analysis?
I think so. I mean, I can't say exactly that, but it's certainly foolish to try to save money by getting rid of. And what I'm basically saying is, look, this is working. What you have works. You are doing better than you would be doing if you didn't have this. And cutting it is not going to help you. Cutting it is going to make it worse, and then you're going to have to re-implement it. And re-implementing, as you saw, is not guaranteed to to get the kind of cost savings that you want, or at least not in the short run. So I think, I guess what I basically said is, yes, I do agree with you.
Well, you know, I'm coming from an advocate's perspective, and you're being more precise, but, you know, it's sort of a lesson learned. You don't necessarily, in a time of recession, want to be one of those states that's starting from scratch. You want to be a state with an established program. The other thing that I think I heard you say along the lines in there somewhere is that running two systems is more expensive, and I really think that's a very important observation, because I think it's worth deconstructing if people are not getting savings they expect from investments, why that is. Another thing that I think your analysis clearly would consider, but I'm not sure policymakers consider, is they're not always looking at the fact that more people were served, the population is growing. They're just looking at the total number of the total amount of costs. But the other thing that people aren't always thoughtful about in policy conversations is the fact that they're allowing the nursing home budget to continue at the same rate, and even have given raises to the nursing homes, so those expenditures are going up, and they're considering the cost of the home and community-based services. Yeah, exactly. That's what I was thinking of. And so when people say long-term care has gone up, they are not always being thoughtful about the fact that it is more expensive to run two full systems than it is to reduce the nursing home costs while you're raising the home and community-based services. And so I think that was something I really took away that was useful from your analysis.
Well, thank you.
Joy Riley, I have a question.
Sorry, Joy, go ahead.
Okay. First I wanted to comment on the last thing that you said, because in California, the LAO, I think it was 2010, came out with, what if IHSS was completely eliminated, what would happen? And they did a cost comparison of nursing homes and IHSS. And one of the things that they said was a benefit of nursing homes was that people exited nursing homes earlier than people exited IHSS. And so I don't know if that was because people died, or if it was like rehab. I wasn't quite sure. But there is definitely here in California a bias, because they did increase, nursing homes budget when they gave everybody across the board on IHSS 3.6% cuts. And they're also having on the chopping block triggers for domestic and related services and other cuts to IHSS. But what my question was is that when you're comparing, the wage increase, or why there would be an increase from 2002 to 2008, it isn't just because more people are coming on the program. It could be that there is, definitely people are aging and becoming more disabled, but also there's now, a push for people, for caregivers to have a decent wage, above minimum wage, and health care. So that could also be what's driving up the cost. Also, what I wanted to also make a comment on or question you is that when you're comparing nursing home expenditures, are you taking into account when they send people to hospitals or to other places and they keep a bed open and they double dip, and what those other extra added expenses are, or is it because there's different ways that they shift the money?
So I got that question. Did you get that question, Steve?
Well, no. A better analysis of this would be, a better way of analyzing this would be to do a much more detailed analysis of individuals and compare, follow them over time and see what happens when they transition from the community into a nursing home, and then add that up, aggregate that to the program level. I can't do that with this kind of data. All I have is the long-term care expenditures to make a comparison, and they don't include. I don't think they would include hospital expenditures. They would include keeping the bed open for the person. But we're already showing. What we're showing, which is home and community-based services, save money even just for the long-term care budget. In fact, hospitalization rates are lower for people who are living in the community than for people in nursing homes. So I think in general, if you add the extra expenditures, you're only going to do better. I wanted to point out what would have happened. When I'm showing now, back to this graph showing the trend in expenditure in California of nursing homes versus IHSS. IHSS went up, and I actually have another graph that I can't show you right now, but it shows the per person expenditure for IHSS participants, which is pretty flat over the period. All right, what went on with nursing home expenditures here? What went on is that nursing homes in red here got a big raise in 2006. If they hadn't gotten a raise, let's see if I can draw this. If they hadn't gotten a raise, their expenditures would have declined, just like they did in other states. And we would have seen, a flat, flat expenditures overall in long-term care. So to blame IHSS for the increase in California's long-term care budget when nursing home expenditures have been kind of artificially inflated by getting a raise is, I think, kind of disingenuous. So this is why I brought this up. But that's
Thank you very much. Ellen, I'm going to defer your question about where to focus in advocacy, because I don't want to put Steve on the spot since he's bringing us the facts here. But I want to say that we're going to be launching an advocacy toolkit before the end of this project in September, and that's exactly the sort of thing that we're going to kind of be bringing all these details together and helping people to define for themselves where a good place to focus their advocacy is. So I'm gonna defer your question about where to focus until the later presentation, and I want to stop now and let people know that when you sign out from the Illuminate platform, you'll get an evaluation. Please do fill it out. We really appreciate your feedback. It helps us improve these as we go along. And I just want to thank Steve Kaye so much for sharing his expertise. I think one of the big things here is that we have some real data, some real academic research, and there's been just a dearth of research that considers these questions, because in the past they just haven't been considered important. And so to have researchers and academics at UCSF who are considering these things, and then would take the trouble to come and help us try to, understand the data and the arguments, is absolutely invaluable. It's a golden resource. And Steve, we're just so grateful for all of your work and who you are and what you do, and for being here today. We're just about out of time, but go ahead.
Can contact you or ask you a question? Ask the question or your email address.
If you want to send a question to me, this is Laurel. I will interface with Steve so he doesn't get too many messages. My email address is laurel@cfilc.org. I'm actually going to put that in the chat box right now. I don't know why I didn't think of that. And I will, pass along any follow-up that we have. Whoops, I sent it to Alan instead of the whole room. Okay, good. So if there's a follow-up, you're going to find it ability to, I can't talk and type. There we go. There it is. If you have a final question for Steve, go ahead and send it to me, and I will make sure that he gets it. So,
as I was about to say, thank you very much, Laurel, for inviting me. It's been my pleasure and an honor to participate in this. Thank you all for listening.
You're wonderful. Thank you so much, Steve, and thank you all for joining us. We hope you'll come back next month for our communications training. Be sure and visit this training again on our website if you want to see some more of the details, and thank you very much. Bye-bye.